Okay, thank you very much. We are switching gear now, so we'll talk about AML management. So again, thank you for the organizing committee, and thank you for Astellas for sponsoring this talk. So this is a presentation about management of AML for an adult patient, consensus of Saudi Society of Blood and Marrow Transplantation, which has been done 2 years ago, and published in 2021 in JCO Global Oncology. And so this is what I'm going to talk about it. So we know that AML has a global, huge burden with incidence of having this kind of disease is relatively lower in our patient population if you compare it with the UK, for example, but probably because UK, they have better registries that can capture every single AML. This is one possibility, and other possibilities there. But in general, AML considered the second most acute leukemia in our adult patient population, with fairly large number of patients. So it's estimated now around 200 or 250 newly diagnosed AML case per year in our country. So the SSBMT decided to, at that time, to do management recommendation for AML. And the aim is to study what kind of epidemiological data we have for AML patient, and study what kind of therapy provided, and also to come up with recommendations. So a panel of 10 experts from 8 institutions in Saudi Arabia, they were able to review the literature and develop this consensus statement. And they review literature related to AML epidemiology in Saudi Arabia, treatment patterns and outcome in Saudi Arabia, as well as literature related to the current advanced AML management in general. So what we found that there was really a limited data of about AML in Saudi Arabia, limited published articles about epidemiological data in AML. There is no AML registry, for example, to capture every single case. And also there was a lack of local economic studies to study the impact of AML burden in Saudi Arabia. We know that AML has a huge burden because those patients, they receive intensive chemotherapy, they require prolonged hospitalization, and more than half of them probably they will go into an allogeneic transplant using myeloablative or non-myeloablative. And more patient population from AML, they become more and more eligible to the transplant because of innovative way of doing transplant, even for elderly population. So this constitutes a huge burden on the hospitals, so there is no local economic studies to study such burden in our kingdom. Also, we noticed that there is a limited availability of advanced molecular testing. So most of the institutions in our country, they send their molecular testing, including even simple fish analysis. They send it to outside institution, outside laboratory, and some of them they send it to outside even the kingdom. We also noticed that the lack of AML clinical trial in Saudi Arabia has a huge impact and huge effect on making the available novel cutting-edge medication available for our patient. So that's something that every single stakeholder should think about localizing and importing clinical trial for AML to the region. Then we come up with kind of treatment algorithm and diagnostic algorithm. We suggested this diagnostic algorithm so smaller hospitals in the peripheral area can utilize this algorithm to guide the process of diagnosing any suspected new acute leukemia in general. So we thought that any peripheral hospital who does not have the capability to do the staining or flow cytometry, or they don't have urgent fish for BML RARA that can, the result can come within 24 hours, probably they should refer the patient immediately to more specialized center, especially that we have now our electronic referral system, which is very efficient and that can transfer patient from peripheral hospital into tertiary hospital within 1 or 2 days. Then subsequently we recommend a set of diagnostic workup that is essential for AML, that can guide the treatment, the choice of treatment, that can guide the risk stratification, whether those patients can go into transplant or not. And also we recommend also to do MRD monitoring using different technique, and consider sending them even to outside external laboratory if it's not available in-house, because this is essential to guide the treatment, the treatment for the patient. For the induction in general, we thought to be consistent with the currently published guideline, including ISMO and NCCN, so it's not that different really. Keep in mind that this recommendation was in 2021, which is 3 years ago, 3 years ago. Now we have even newly approved upfront medication, especially for elderly patients. So depending on the patient fitness, patient can go into their treatment. For fit patients, we recommend that favorable patients should receive gemcitabine or oligomycin in addition to their 7+3 therapy, based on meta-analysis that showed superiority of the use of GO. And for patients with FLT3, they should have FLT3 inhibitor to be added to the treatment. And for secondary AML, the use of CEPIX 351 is highly recommended. For unfit patient, depend on the mutational status, but overall, venetoclax plus hypomethylating agent or low-dose RC is the currently approved treatment, and I believe that most of this, almost all the centers, they're doing this kind of treatment. For the consolidation phase, this is also again consistent with the international recommendation. Intermediate and adverse risk AML who are fit for to receive allogenic transplant should go to allogenic transplant, as well as those with secondary AML. For relapse refractory patients, it depends on the patient fitness. But the most important thing, even for unfit patient, is to consider allogenic transplant for those patients using reduced intensity or non-myeloablative conditioning regimen, depending on the patient fitness. And also the mutational landscape also can help to guide the therapy for patient with relapse refractory AML. Nowadays we have gilteritinib is approved for treatment of relapse refractory AML patient, even for those who are fit for intensive chemotherapy. And this treatment modality can be very useful to bridge patient for stem cell transplant. So, for conclusion, for this specific talk, AML is uncommon yet commonly fatal kind of malignancy, and the interesting thing that the incidence is increasing. If you look to the global data about the incidence of AML, it is actually increasing. And so we need detailed epidemiological data to be available for policymaker and to help in allocating public health resources to relieve the burden of AML. And I believe that novel therapies, either single agent or in combination of chemotherapy, is going to drastically change the landscape of AML treatment in general. And it is very important to develop local guidelines to unify management within our country. Especially we have a smaller size population, so unifying their treatment, establishing a registry to capture their data is going to be very helpful, again, for policymaker and others. So, the sponsor asked me to present two case discussion. So I'll start with this case. This is an 80-year-old female who known to have hypertension. She presented to local clinic with 1 month history of progressive fatigue and weight loss. Initial workup was remarkable for leukocytosis and anemia and thrombocytopenia. So she was transferred to our hospital as a case of suspected acute leukemia. She was ECOG 2. Her initial WBC was 143 with 95% plus percentage, hemoglobin 110 and platelet 110 and hemoglobin 104. So we did a bone marrow which showed hypercellular bone marrow, 90% blast with immunophenotype consistent with AML. Her initial cytogenetic were normal female karyotype. Her initial molecular testing showed presence of NPM1 and FLT3 TKD mutation. So she was started on aza-venetoclax as a standard for elderly and fit patients, and day 26 bone marrow showed complete remission with incomplete count recovery. There was no MRD detectable by flow cytometry, and NPM1 testing and FLT3 testing by PCR was not detectable. And later on, the in-house NGS panel, myeloid panel, showed the presence of IDH1, RONX1, CBB alpha, NPM1 mutation, as well as FLT3 TKD mutation. Subsequently, she had like a total of 4 cycles of aza-ven, and she was in complete remission. Her count recovered nicely. However, she decided to stop treatment, unfortunately, and to try traditional herbal therapy. And this was around the time of Ramadan, so she wanna stop treatment. So she had this break. However, 3 months later, she presented, unfortunately, with disease relapse, with bone marrow showed 60% blast, and she had NPM mutation again. But this time she had FLT3 ITD instead of TKD, which is known for around 10% of patients they can switch between a different type of FLT3 mutation. And her ECOG status was 2 at that time. So again, we started aza-ven, and we add sorafenib, of course, with dose modification, like shorter exposure to venetoclax, longer exposure to sorafenib. She had 2 cycles of therapy. And her bone marrow, after 2 cycles, showed again complete remission with incomplete count recovery, and NPM1 and FLT3 ITD at that time was undetectable. So, because this is a kind of intense therapy for relapse patients, so treatment was held multiple times due to cytopenia and recurrent infection. And then when she's in outpatient setting, we resume a single agent sorafenib, trying to control the disease until full count recovery, and then resume the treatment again. However, 2 months later, repeated bone marrow showed severity of around 40% with 80% blast because of persistent cytopenia. We did the bone marrow, and again, re-emergence of the FLT3 ITD and NPM1 mutation as well. So at that time, gilteritinib was available in our institution, so this was started as a single agent. It was initially well tolerated, and bone marrow biopsy after 6 weeks showed hypocellular marrow with 10% blast by morphology. However, when we did the flow cytometry analysis, it was mainly regenerative blast. It wasn't similar to the original immunophenotype. However, the FLT3 ITD and NPM1 was still detectable. Currently, she's around 6 months on after initiation of gilteritinib with no evidence of disease progression. Actually, like she progressed like a few days ago, but she used to have like a lot of transfusion support and so on. This is case number 1. Case number 2. This is again a 60-year-old male, heavy smoker with query history of MPN, used to be in hydroxyurea. We don't know why. He was treated in other hospital and had history also of rheumatoid arthritis on treatment, sometimes on a steroid and so on. He was diagnosed in outside hospital with AML with a bone marrow showed 90% blast. He was started in 7+3 at the outside institution. However, post-induction therapy showed persistent blast at 40%. He was transferred to our hospital as a case of refractory AML. So in our hospital, he was clinically stable, ECOG performance status 1. His CBC at presentation showed WBC 24, hemoglobin of 10.6, and platelet of 47, and bone marrow showed 63% blast, which were positive for CD34, 117. He has partial expression of CD7 and 123 as well. His cytogenetic showed translocation 911, which is a high-risk translocation or intermediate-risk translocation, and deletion 13. HLA typing and donor search started, and we started him actually on AZA/VEN. We thought that this is a good combination for patients with who failed intensive chemo and who are actually have like secondary, questionable secondary AML. A few days later, molecular data showed presence of FLT3 ITD mutation, so we add actually gilteritinib to aza-venetoclax, and bone marrow biopsy at day 28 showed complete remission with incomplete count recovery, and NGS later on showed the presence of RANX1 frameshift mutation at variable allele frequency of 48%. So he was started in cycle 2 with the same combination, again with some dose adjustment, and bone marrow showed that he's in complete remission, no MRD detectable by flow cytometry, and no FLT3 ITD detectable at that time. So he underwent match-related donor reduced intensity allogeneic transplant using flu-Bu2 plus very small dose of ATG, 1 day actually, and he had his bone marrow biopsy at day 30 post transplant showed again complete remission with no FLT3 mutation, and I was able to initiate gilteritinib as a maintenance post transplant around day 45. His chimerism at day 60 showed full donor engraftment, including T lymphocyte engraftment. And around day 120 post-transplant, he developed worsening cytopenia. So we blamed gilteritinib. So we held gilteritinib to observe this cytopenia, which improved slowly over the next few weeks, but not fully really recover. And we did a chimerism subsequently, which showed a full donor engraftment in the myeloid component. However, the T-cell lymphocyte engraftment was not fully engrafted. It was mixed chimerism for T-cell. And then subsequent bone marrow showed complete remission with no MRD by flow cytometry. However, this is the first time to have FLT3 detectable post-transplant. So immediately we reinitiate gilteritinib again, and we give him 1 dose of DLI, small dose actually, as a kind of preemptive approach. And subsequently we retested his FLT3 ITD, which was not detectable at that time. And we repeated his chimerism. Still he has mixed T lymphocyte chimerism. Currently he has no evidence of disease 1 year post-transplant. He actually underwent a second DLI, and he's continuing gilteritinib with normal CBC, and we have his chimerism assessment still pending. Thank you very much for your listening, and happy to take any questions.